Good morning, everybody. This is Dr. Jasper and Jeremy.
Hey guys, how you doing?
All right, Painless with Dr. Gabriele Jasper. Well, today we got a lot of things to talk about.
Yeah.
We even have a guest, Dr. Chris Radcliffe. He's on his way in.
Mm-hmm.
And the topic of today with him would be how to do spine surgery without general anesthesia.
Right.
Basically, they call it, it's becoming very, very talked about and used worldwide. However, very few people are using it.
Right.
It's awake spine surgery.
I did that.
Yeah, I mean, you did it, and,
Yeah.
and it's nothing for a good anesthesiologist to figure out how to do that.
Yeah.
But we're not going to get into depth right now until Dr. Radcliffe comes.
Yeah.
But I'd like to introduce myself again. I'm Dr. Gabriele Jasper, MD. I'm a surgeon, anesthesiologist, interventional pain physician. And I like to take care of patients with pain, get rid of their pain.
Yeah.
And we do a pretty good job at the Jasper Spine Institute. We have Dr. Skoblar there.
Yeah.
Who's new, Matt Skoblar, and he's very, very good. And he's getting up to date with all the stuff, and he brought his own stuff into the practice, which is great.
Yeah.
Fresh out of fellowship training in pain.
Mm-hmm.
So we got a lot of great things going on. We have the surgery center over there. We got new doctors coming in. We have all the state-of-the-art equipment in there.
Yeah.
No shortcuts. We don't get cheap stuff. We get the best you can get. And that's how I've always been, whether it comes to a car or an instrument that you need to do spine surgery.
Yeah.
Or any kind of procedure in the operating room. But just to give you a little heads up on what I do, for the people who maybe are just tuning in now at this podcast. And tomorrow it's going to be on the radio. What radio station is going to be on?
It's 104.1. It's the what's the country music station called?
Thunder?
No, it's not Thunder. It's Cat Country.
Okay.
Cat Country.
Well, I mean, anybody listening to this right now doesn't have to watch it.
Yeah. But no, it'll be live tomorrow morning though. Yeah.
Yeah. At what time?
Before
the roosters get up.
Yeah, before the roosters get up. So I think it's like 6 to 7, 7 to 8. That's what we do. Yeah.
All right. So, like I said, I do interventional pain, which means that we look for the pain generator and we do something to get rid of it.
Yeah.
We don't cover it up. We find it and get rid of it. and it's a unique type of specialty when it comes to pain.
Yeah.
Most of us, not all of us, but most of us, like myself, we try to avoid any major surgery. And in the future, once the surgeons catch on, they're going to realize that there's a lot of stuff that doesn't need major surgery.
Mm.
Even the insurance companies start to catch on now. They're not paying as much for major surgery, so they're not using that as an incentive to do major surgery. In fact, insurance companies now are starting to get wise, hopefully, and they continue to get wise to do more appropriate, inexpensive, safer, faster recovery, less trauma, less scar tissue, just overall, just better procedures that we've developed, and it's been developed all over the world.
Right.
And we're developing it right here. And I've been very influential on spreading the word and teaching doctors how to do these minimally invasive procedures.
Oh, yeah.
The industry, which means the people who sell instruments to do surgery,
right?
They contact me every day.
Oh, yeah, they do.
Just to see if what they sell is good. Not always good.
Yeah.
But a lot of them are very good. And this is how we get to do these new procedures with new instruments.
Yeah.
There's always somebody down there. I always say there's somebody in their basement figuring out how to do things better.
Right. The next mousetrap, right?
Yeah, it's amazing how you think technology just can't get any better, but it just does.
It does.
Whether it's medical, aeronautical, or boats, cars, everything just gets better and better and better.
Yeah. Newer and newer innovations are happening every day. Yeah. So
there's people that train and have the desire to invent and get new things. But anyway, I take advantage of everything that's new, that's safe and good.
Yeah.
For the patient and less traumatic. And that's basically what interventional pain is. Now, in order for us to get to that point where we do minimally invasive spine surgery, we got to go through some hoops, which some of them are good. For example, epidurals. Epidural's been around for a long time.
Long time.
And somebody might think that that's a Band-Aid. It's not a Band-Aid because probably 80% of the people I do an epidural on get better. And they're done. In fact, they say 80% of the people, you got pain somewhere from the spine, it goes away on its own. If you rest, maybe some physical therapy, but the proper physical therapy without irritating the nerve that's inflamed.
Sure. Yeah.
It goes away. So the job is hard and easy at the same time. You just can't be too aggressive. Little is better. I keep repeating these same things. So these epidurals calm down the inflammation of the nerves and patients get better. However, if there's a pain generator smushing that nerve, smashing it, crushing it, it's not going to get better. You're going to feel a little bit better a couple of days, and then you need to go to the next step.
Yeah.
And the insurance companies know about this, and they've created these protocols, criteria that you have to go through, which are not necessarily the right thing, but usually are, because they have doctors figuring these things out. But it's standard stuff that they do.
Yeah.
They say, okay, you need to do physical therapy, take pain medications, take naproxen, Aleve, aspirin, Tylenol, all that stuff before you can get an MRI sometimes.
So, yeah.
And a patient comes in with weakness, which is usually an exception. You can probably get an MRI right away, but they come in with severe pain shooting down their leg. I know as an interventional pain doc for 27 years, I know that it's probably a pinched nerve in the back, and it's not going to get better by taking an aspirin or a Motrin. It might get better on its own slowly if you rest, but most people can't rest for 2 weeks and get a position and don't move,
right,
where it doesn't hurt and it goes away a lot of times.
Yeah.
But
I remember that when I was in so much pain, just trying to find that one position.
Hey, here comes Dr.
that would
Radcliffe.
reveal
comes.
everything. How you doing?
How are you?
How you doing?
Nice to see you here. Right here. I got you all set up.
Let's check you on
All
the
right.
camera
How you
here.
doing? All right.
Yeah,
here
this
it
is
comes.
our superstar coming in, Dr.
Superstar
Radcliffe.
today.
Yeah.
And when he comes and does surgery, he's a superstar.
You can here. Let me move that around. You keep talking, Doc.
Anyway, so as I was saying, the technology is fantastic. So we find a pain generator and get rid of it. That's what it is.
This one right here. Let me bring you up. Yeah.
All right, here he is. You got it?
Hi.
All right, we hear
Good
him.
morning.
Dr. Radcliffe, last minute, I asked him to come in, talk about some good stuff today. It was actually his idea.
Yeah.
Because we did a case in the surgery center, Jasper Ambulatory Care Center, this week, and it was very successful. And it was, you can't really call it quite awake spine surgery, but that's the topic. What do they call it in the surgical field?
Yeah, so awake spine surgery is kind of increasingly of interest. The idea that you don't have to do general anesthesia and that the patients are, not running around running a marathon, but that they're at least sort of, awake and tell us how they're feeling and things like that is really valuable. It implies, safety, and you can only do it if you have the right center with the right, partners, the right anesthesiologists, and excellent kind of like technique. And I was very impressed and thrilled that we were able to do a somewhat awake light sedation discectomy at the Jasper Ambulatory Care Center. It really, it was smooth. The patient didn't even have to really wake up because she wasn't ever fully under anesthesia. And so the recovery is quicker, the nausea is less, and people just bounce back really quickly. I think that's going to be the wave of the future for minimally invasive spine surgery. If you're not damaging too much tissue, if you're efficient, you don't need to put the patient totally under anesthesia. And we're seeing that in other areas of orthopedics also. obviously a lot of arthroscopy, a lot of knee scopes and things like that are done with people, at least somewhat awake.
Right, right. Now, did you interview her as to what her point of view and experience was through all this?
Yes, absolutely. So I've called her. It was on a couple days ago, but I've called her essentially every day
Right.
just to check in and see how she's
Sure,
doing.
sure. Yeah, yeah,
She's
man.
doing really well. She feels better. She didn't have a lot of any of the nausea that people sometimes have after anesthesia.
Yeah.
And I mean, I don't know how to the explanation for it, but there are plenty of people who just feel kind of drained after surgery and a little bit groggy, confused after anesthesia for
Mm,
a couple days, even a week or so, and she didn't have any of that. I mean, her recovery was really akin to that of an epidural.
right.
And again, I'm thrilled that we're able to offer that for our patients. This was a patient of Dr. Jasper's, whom he referred to me, and I mean, like, what better continuity of care than having him in the room,
Yeah, totally.
like looking at the X-rays and kind of just dialoguing, and it was really wonderful.
Yeah.
I mean, there's so many different ways we could do awake surgery. For example, Jeremy
Yeah.
had endoscopic surgery, totally awake,
Mm,
no anesthesia,
yep.
because I had to do the procedure and we had no anesthesiologist available, and he had it was
Yeah.
you know it was a borderline emergency
Yeah.
case. It was urgent because he had foot drop.
Yeah, yeah.
And if you got to get in there quick, because the longer you wait, the less chances of it coming back. So I
Yeah.
explained it to him. He goes, "I'll just bite the bullet. Let's do it." So there's ways of doing it where the surgeon can use a local anesthetic in the site of the surgery. There's different ways, and that's what I did. And he was relatively not pain free, but it was very tolerable, the procedure.
Actually, the procedure itself was great. I mean, I didn't really feel pain while you were doing it. In fact, Dr. Jasper repositioned the monitor so I could even watch it going on, and he's like pointing to me, showing me as he's operating exactly what's causing my pain, how he's removing it. And it wasn't, people always look at you like they're shocked that you went through something like that without anesthesia or anything like that, but it wasn't the worst thing I've ever done, and it's a testimony to the faith I had in Dr. Jasper. He said to me right before, he says, this is something that it's done in like far off places like Korea and all of that or whatever. He says, but there's smaller people, smaller instruments. He says, but I have a strong feeling with your, how you deal with your pain, that you can get through this and it'll be fine. And I'm like, okay, you're the doc. Yeah.
This reminds me of a story. It's a funny story. I was pretty much fresh out of training for anesthesia, a board certified anesthesiologist, and these are the days that they didn't do open. We could talk about it if the lay people understand. Some people have abdominal aortic aneurysms, and what that is a dilation of their aorta, which is the biggest artery in the body, and it starts to dilate it. There's only one end to that, and that's bursting and most likely not surviving. So when you catch it right away, which is normal routines, people have high blood pressure, stuff like that. You catch it, you can operate on it. And when I first came out of surgery, I did surgery also, but I first came out of anesthesia. I was very good in regional anesthesia. Regional anesthesia, we do spinals, epidurals, and that's basically what we're doing with interventional pain. But I had a patient that was, he wasn't. He had a AAA, which is abdominal aortic aneurysm, which was leaking, and they had to operate on him. It was a very small leak, and he needed to have an operation pretty urgent. But he didn't have. He had high blood pressure. He didn't have a great heart. He suffered from shortness of breath at times, and also angina, which is chest pain. So this guy was a disaster. So what I did was I did all my interventional stuff. I put in an A line in him, and which is an arterial line you can keep constantly keep an eye on. But I did an epidural on him with an infusion, the kind that you give a woman who's in labor.
Oh,
You put the epidurals in when a woman's in labor,
yeah.
and if it's done right, they don't have any pain. They just have a baby.
Wow.
And it's
Yeah,
like the
yeah.
best feeling in the world. So I did this to this man because he was at high risk to have general anesthesia. Chances are I wasn't going to survive.
Right.
So I did it and I titrated it in, which means that you put a little bit in, and you measure what's numb. And I had it up to the bottom of the nipples
Huh.
where it was numb from there down. But yeah, and you got to hydrate them up with a lot of fluid, because when you do that, the blood pressure could drop out. Because
Right.
when you do what they call a sympathectomy, all the blood vessels dilate below that area. So if you have five liters of fluid, to the brain and to the heart and everything could drop out. So you basically put in like 10 liters of fluid almost.
Right.
That's an exaggeration, but you titrate them up to where you give the epidural or the spinal, and an epidural, you do it slowly so they don't drop out as fast. So, I didn't discuss this with the surgeons because they weren't even around, and I did the best thing for the patient. And I gave the patient a little bit of sedation, so he's kind of dozing off. So, they draped the patient. They weren't paying attention, with two surgeons that were just yapping away, telling each other's jokes, and they made an incision from the base of the of like just below the nipples, the base of the sternum, all the way down to the symphysis pubic, which is right by the pelvis. I mean, probably like a foot long, and the guy was a big guy. Wow. And they spread it out with the Buck Walters, a special type of, what that is, and they spread out, and they're operating on them and talking. In about an hour through the procedure, they start telling a joke, and the patient starts laughing, and they're like, "Who's that laughing?"
Right.
And the patient said, "It's me, doc." And the belly's completely open, and they look at me and said, "Patient is awake? This is a AAA." I said, "Yeah, the patient's awake." So you can not only do open, big abdominal. I don't recommend it. You got to really know what you're doing.
Yeah.
And most people can't do that. But spine surgery would be easy to do like that.
Yeah.
Easy.
I'll say a couple comments. It's funny. First, I mean, the joke is there's no I in team, and certainly, I mean, part of the credit goes to Dr. J. Part of the credit just goes to the excellent team he's built around him in that facility. And I mean, it's remarkable. You can feel like everyone cares and everyone's interested in safety. So, we all just want to make sure people just get in and out, have a good day and a great outcome. And so that made me feel more comfortable, because I'll tell you, one of my friends, Dr. Alok Sharan, is a little bit north of here, kind of, brought my attention to awake spine surgery. When he first said it, I mean, I envisioned like people just, like Civil War, just screaming and biting on, corks and things like that.
Right.
But Dr. Jasper's right. With great technique and with, kind of careful monitoring, you can do it. And it's so much more empowering to the patient. And that's what, like Jeremy was alluding to, I think, a moment ago, that like being able to watch on a screen and see, this is your disc herniation. This is your problem. Watch it gone. It's just very empowering. And so, when you hear us talk about people being awake or light sedation, please don't think that they're just screaming and moaning in pain.
Because if they are, I'll slap you.
Because I think awake spine surgery really is an exercise in pain control, and in prophylactic, preemptive pain control. And once you control that pain, you can really do a lot of things.
Yeah, I was actually, when you said that about that patient, doc, I was actually on the table with you doing that, and I was cracking joke. One of the nurses said to me, like, "Jeremy, are you laughing?" And I said, "Yeah, I'm just thinking like the things you ask your friends to do to you,
Yeah. Yeah. I mean, and there's so many different techniques of doing the awake type surgeries, whether it's spine or anything else. But when you say awake, the patient is there awake and talking to you. But we give an intravenous fluid all the time. If you're on a table, you have to be ready for anything. So you need to be prepared. So the patients are on monitors, right? There's an anesthesiologist there keeping a close eye on you, and by the way, it's not like you're wide awake. We give you highly sophisticated medications that, number one, relieve your anxiety.
Yeah.
I go to the dentist to clean my teeth. I wish I had an IV with medicine.
Yeah.
Can you imagine me
Totally.
going for spine surgery? What do you mean? What do you mean? So patients look at you when you're explaining the procedure to them. They're like, "Are you?" They start making these faces, right? They make these faces. Not everybody. People, do whatever you want, doc. But some of them are like, "Are you kidding me?
Right.
You're gonna do that to me?" I said, "Well, what? This. I'm just telling you what." I'm just telling you what needs to be done, in my opinion. You're the boss. You make your choice. But I tell him, I said, we're going to give you medicine, number one, to take away your anxiety.
Right.
The first thing. And I tell him, when I give you that medicine, and if I tell you that there's a tidal wave coming, it's probably going to wipe out half of New Jersey, and we're right here, you're going to say, oh, I don't care. And you're going to have that attitude. So that's relieving anxiety.
Sure it is.
Right?
Yeah.
And number two, the same medicine, in fact, and it's called Versed, if anybody wants to know the name of it, it takes away your memory when you use a certain amount of it.
Yeah.
You use, and it's a magic number for everybody. It could be 1 milligram or 3 milligrams or 5. I went in for my shoulder surgery, and the anesthesiologist says, asked me, he says, and it all depends on the patient. That's what's important, the patient's history. For example, I go home every night and have a scotch with my father and my son.
Right.
Then maybe my father insists we'll have a second. I'm good with one, but he's like, hey, I still have ice in my glass here. and then we have dinner, and I have at least 2 glasses of wine every night. So with somebody like me, you don't just give 1 milligram of Versed.
Right.
So I'm in the holding area, and they're going to give me an interscalene block, which I know how to do. You do an interscalene block, and I said, well, that's cool. I want to see the new ways that you do it, the different medications, because we used to do it stick the needle in the neck and ask the patient, and I'm from way back now, I'm dating myself. Do you feel any tingling in your arm and down your fingers? They were blind. I feel. Oh, doc, that hurt. Oh, back off a little bit. How about now? No, it's tingling. All right. Whoop. We give 20 cc's or whatever. First, you back out, make sure you're not in a blood vessel, and you give it to them, and you numb the whole shoulder down. And our medication used to last for maybe 2 hours. Now they got a medication that'll last for 72 hours.
Jeez.
But in the meantime, the topic of the story was, the guy's a smart anesthesiologist, and he knew that the way I drink, that he's going to take a lot. So he draws up 5 milligrams of Versed. I'd never give 5 milligrams of Versed in one shot. He goes like this. Whoosh. I said, wow, doc. I said, you must think I really, and that was the last thing I remember. And they told me later on, nurse told me later on, I said, until they actually put me to sleep, that I was talking, telling jokes and everything.
Yeah. The first time I had an endo with you, I think it was Con Wynn that did the anesthesia. I didn't remember anything, and like afterwards, you were telling me, I was like, "Oh, you were awake the whole time. We were having conversations and stuff," and I was like, "Wow, that's amazing," because I didn't remember a thing, not a thing. It's quite amazing.
So that's the key. It's really good pain control. And it does allow you to do things that you probably wouldn't do otherwise. People who, you would worry about if they're under general anesthesia, maybe they have an airway issue or some other problem, and you can safely do them under what we call regional. And so there are people who, I know my friend tells me, travel in from all over the country to come and see him and get, a discectomy, which a lot of good spine surgeons can do, but we're like my friend, and now we are comfortable doing it without general anesthesia and maybe avoiding some of those complications. And anesthesia is really safe. I mean, for the most part, people tolerate anesthesia and bounce back just fine. But if you can avoid all the medicines, avoid that foggy head, it makes a world of difference.
And the minimally invasive stuff today are being done in ambulatory care centers. They're being done in surgery centers and same day surgery. So technically, they got to go home the same day.
Yeah,
and that's the best way to get them out of it. Even the hospitals are talking about doing it this way, so they don't keep them in the hospital too long. It's probably not the hospital pushing it because they lose money.
Right,
probably insurance companies pushing it. But it's not just money. It's like like Dr. Radcliffe said, you wake up from general anesthesia, depending on your metabolism, depending on your age. I remember I did anesthesia on my friend's father, who was 85 years old, and I happened to run into him. My friend, I happened to run into him a month later. I said, "How's your father?" He goes, "Hey, I just woke up." You know what I mean? Because you're 85 years old.
Yeah.
It takes you time to metabolize it,
Yeah.
and you know what? It puts you back a little bit mentally. You get more forgetful. It's not a good thing if you could avoid it, but it's not a bad thing. Like Dr. Radcliffe said, it's overall very, very safe.
So
Yeah.
I think that it is for those folks who maybe have a history of not tolerating anesthesia well, and or for people who are just worried about it or have a history, certainly for people who have an anesthesia allergy, like malignant hyperthermia, it's probably worth finding someone who does, awake techniques in your community. And if not, it's probably worth flying in and just having us do it if you need a spine procedure. Not all the surgery's done awake. I've done a couple of surgeries on the neck also in Dr. Jasper's center. I've done disc replacements. I've done even a couple of fusions. So I mean, it's not like everything we do the patients want.
Yeah. That's
But
a
if
good
but if-
distinction.
But if we can do it, I think it does add significant value. And something Dr. Jasper said that I'll kind of underscore, or two things actually. It used to be that we felt like hospital patients would just be, oh, you're not going to keep me in the hospital. I'm not going to stay in the hospital.
Yeah.
I feel like with COVID in particular, it kind of like laid bare the fact that sometimes you don't want to hang out in a hospital. I
Yeah.
mean, there's a lot of sick people in hospitals and a lot
Sure.
of germs and
Sure.
problems, and you're always more comfortable in your bed, in your house, eating your food. So I don't think it's a bad thing. And I feel like honestly, post COVID, people have started to recognize that. The other key is that, I mean, we've got a board certified anesthesiologist right there watching the whole time. So I mean, if there was an issue, I mean, there's really no one more capable of addressing the situation. If we felt like somebody did need to be put under anesthesia, like I obviously, Dr. J is right there, or Dr. Wynn, and can do it, expeditiously and safely.
And we got a great crew there. Everybody. Actually, we just finished the ACLS certification again. We're always up to date with that, and we have RNs, registered nurses. We have technicians, and we have Dr. Radcliffe is there. He's a physician. I'm there. You're in the best hands for if there's and the nurses are intensivists. So especially recovery room. So if anything's going to happen, that's a good place for it to happen. We don't like it. It's too much paperwork, but it's not, we're there prepared for it.
Right.
But and the different techniques of awake, as we talked about, spinal anesthesia and a little bit of sedation. And what's important also, you have to have a good surgeon like Dr. Radcliffe that knows how to administer local anesthetic in the site.
Yep.
Did you ever hear about? I was reading about they sometimes they take a like a sponge or something, or
Yeah.
that they kind of soak it into the right near the once you make the incision, right near the I guess the ligament or the
Oh yeah.
dura area, just to not a high concentration that's going to
Yeah.
paralyze you temporarily, of course. It's only but just it gives you local anesthetic, numbing in that area, and you just can work.
Yeah. I'll tell you a funny story. When I was a fellow, so after you do your like training, your job specific training, like orthopedics, you do a fellowship to do to get extra good in some area of medicine, like Dr. Jasper did pain management. I did spine surgery after orthopedics. So I was a fellow, but you're still learning. And so someone had a discectomy and they were in the recovery room, the area after surgery. And like they had no pain, but they could not feel anything kind of in their private area and in their legs. And they couldn't urinate, which was a big deal. And obviously if somebody has a problem like that, I worry as a spine provider that, could something happen to the nerves? Could there be a hematoma or whatever? But usually that really hurts. So in this case, it was strange that the guy didn't hurt. And then I found out that but I didn't do the surgery. It was one of my co-fellows. And they put in a lot of local over the and if it's right over the dura, that's literally an epidural. So the patient was just laying there with an epidural, and once the local wore off. So you can do that as long as you like advise the patient, tell the PACU, like, hey, you're going to be numb when you wake up, and it wore off, and the person was fine. The other technique that people are doing more and more, and I think we may have to look into this with us, is erector spinae blocks. So there's a way you can take an ultrasound machine and block the muscles along the side of the spine. Again, just like Dr. Jasper's thoracic epidurals, sort of experience, where if you block those pain nerves before they start, talking about the pain that surgery creates, it's tremendous. So that may be something we can try to implement. We have ultrasound machine. We have, anesthesiologists who's experienced with that. And that definitely has been I think a component of kind of aggressive surgical pain management is blocking those nerves.
Yeah. Well, these are great topics. What we need to do is, I think people are out there now. Hopefully, there's enough people out there. And
we got Felix. He's gave us a big smile. We got Meg, who says good morning, and William. He says TLIP block. William Chapman.
Oh, William Chapman. Yeah.
Yeah, TLIP block.
But listen, I only know OR and ER
Yeah.
as far as abbreviations go.
I can't even spell EKG.
We got good morning, doctor. It's Chappie.
Yeah.
Yeah.
I know Dr. Chappie. How you doing?
Yeah. Hey, chap.
Yeah, everybody's getting on here.
Yeah, everybody's getting on.
You know what I wanted to say is that there are a lot of people that listen. Probably there might be more people out there saying, "Oh, I'm never going to do anything like that." Awake, right? But the people that are advanced in their own mind, and they want the state of the art and the safest way to go, are interested in this. So what we should do is probably give them our number. Yeah, people. This is all over the world now. Listening to this, and if they want to come in, we have a great interventional pain doctors in our practice. We have Dr. Radcliffe here, who's a fantastic surgeon, and we do the latest technology. So if you're interested and maybe planning on getting surgery and you want to do it this way, give us a call.
Yeah, the phone number is up on the screen right now to make an appointment with Dr. Jasper, and you just call 732-262-0700. That's 732-262-0700.
And give Dr. Radcliffe's number also.
609-800-DISC 3472.
All right.
609-800-3472.
That's great.
Yeah, give us a call and we'll accommodate you. You come in for a consultation, just to see what our opinions are.
Yeah.
Even if you've had other opinions. I had a patient yesterday who husband had 3-level spinal stenosis.
Yeah.
And I tell him right off the bat, I said, first of all, they only pay for 1 level.
Yeah.
So I'm going to do the worst level.
Yeah.
There's a chance you might. And I tell him, I do 1 level on somebody that I do the worst level, and some of them come back and say, "Doc, I'm good. You don't have to do the other level," because I call it those levels have not reached their critical point yet.
Yep.
And then I say, "But you might come back and say I am no better." Now I tell them, you need to have patience. Don't get frustrated. It's hard not to get frustrated, but don't get frustrated. I'm warning you, if you have no improvement, you might be the type of person that doesn't get any better until I do all 3.
Yep.
And then I give them a scenario why, anatomically it might not work. And I go through the MRI, go through everything with them. And about 6 months ago, I did the worst level, and the guy didn't get any better. Right. And never came back. All of a sudden they're back after 6 months, and they're sitting there, and I don't remember everything. Then we go through the chart, and they were like, "We're very discouraged. You said that we were going to get better." I said, "No, I did not."
Yeah.
I said, obviously, and she's a registered nurse. I said, obviously, you guys weren't listening. And I remember you weren't here all the time. I said, I'm going to explain it again to you. You need to understand this. So I explained it to him. And while I'm explaining to her, she's asking the crazy questions and interrupting me, and he's not even paying attention. I said, now I know why. Now I know why you guys have no clue.
Right.
I said, I'm going to have to wake you up a little bit like this is the kindergarten class.
Yeah.
And I didn't want to be condescending, but you need to understand, because, what's the choice? You might go to a crazy open spine surgeon and they're going to see that you have spinal stenosis at 2, 3, and 4, and they're going to do a laminectomy. Not all of them, by the way.
Yeah.
They might it gives them the license to do a laminectomy, and while they're there, maybe do a fusion on all 3 levels.
Right.
And the way we work it, and also Dr. Radcliffe, we make an effort to see where the worst level is, and the chances are you might get better with just doing that one level. I don't know how it is with spine surgery, but do they pay for 3 levels? I know in interventional pain, most of the time they just pay for 1 level.
So you can do more than 1 level if needed. And as a matter of fact, the surgery we did the other day, I did a decompression at 2 levels, at 2 spots. But it's one of those things. I agree with Dr. Jasper says. I mean, like, sometimes if you're trying to do, kind of the minimal invasive, the least invasive, you may have to come back and do something else, do another cleanup or something. As a matter of fact, the person we did had a spacer, put in, and it worked really well, but just kind of wasn't enough, especially on one of the sides. And so, I was able to go in around that spacer without removing it, without disturbing it, and just clean up one little pocket area. And it made a world of difference.
And that's rare to find somebody like Dr. Radcliffe that would even attempt to do something like that. He's innovated. He looks after the patient. He wants the best for the patient, and little is better. And he has that attitude too. Hey, if a person really needs it, he's going to do it.
Yeah.
Yeah.
If you need big surgery, you need big surgery. And I'm the first one to say, hey, you need big surgery.
Yep.
Well, we got Meg here online. She says, do you also do radiofrequency ablations?
Absolutely.
Yeah.
We did about 4 of them yesterday.
Hey, Dr. Jasper, what would you say to people who say, you're not in my insurance. I don't want to come in and consult with you because, you're out of network?
Well, I believe it or not, a lot of people say that who have added network benefits.
Mm-hmm.
And those are the toughest, because they say, I don't want to spend any money. Well, I mean, you get what you pay for. And I hate to say it, totally, but if you get cheap insurance, added network benefit, who, by the way, that's what I got for my employees. And I feel bad. I apologize now, because it's not their fault. It's astronomical amount of money you got to get for insurance that has low deductibles.
Yeah.
So, but if you get really cheap, I don't really have the cheap ones, but if you get the really cheap insurance, you might have a $5,000 deductible.
Yeah.
And of course, who absorbs that? You can't expect the doctor to absorb it. Yeah. And you never expect to get sick or need something. Yeah. But now you got to come up with $5,000 before the insurance starts paying for anything. Yeah. Now, what you could do, if you have out of network benefits, you can talk to your insurance company and increase the amount of money you pay by month, which usually is not a lot. And you can get lower deductibles, lower copays to make it more palatable. And that's one thing. And some patients that don't have out of network benefits, I suggest that they do get out of network benefits.
Yeah. Mm-hmm.
I know that's not the answer you want to hear.
No.
And I know what you're alluding to. People who don't have out of network benefits, or even if you do have out of network benefits, we work with the patient. We work with the patient.
That's true.
There's very few doctors that do what we do.
Yeah.
And you can go to, in the 5-mile radius, there might be 98% of the doctors doing it the way you don't want it done.
Yeah.
And there's other, because they're either not capable of doing it or they don't want to do it.
Yeah.
Or maybe in their mind, the way they were trained, it's not the right way of doing it.
Yeah.
But you have to go see these doctors, including ourselves, and you got to feel comfortable with the doctor, and you got to feel comfortable that the doctor is you feel he's honest or she's honest, and you got to go with your gut feeling. And like I said, if you don't have the insurance, and we've done plenty of patients, we don't actually, we're about ready to I think what we have to do on our website, and we have to have the prices for everything
Yeah.
actually printed out. Like if you're going to get a laminectomy, it's got to be this price. You're going to get endoscopic surgery, an epidural, radio frequency ablation. There's set prices, right? So we're in the process of doing that. So if a patient comes in, it'll be reasonable. And we work with people. It's not like we need all the money up front type of thing. You know what I mean? You can pay it off, use a credit card. So there's ways of working around. I always say, some people don't think this way, but I always say money is really not the most important thing. What's important is doing the right thing and getting you better, so you can have a good quality of life.
Well, if you're suffering from pain, trust me, nothing's more priceless than getting rid of it. That was a nightmare in my life. I went to doctor after doctor, and thank God my wife found you online, and I met you, and it's history from there. I don't feel pain. I don't roll out of the bed grunting.
It's been a while,
Dr. Radcliffe. I don't. I just roll out. It's been a while since I had a radio frequency ablation or anything like that for my arthritis. Yeah, I feel great.
I want to. Dr. Scarborough, found a patient. Well, found a patient. They found us, and he called me in right away, probably about a month ago or so, and he says, and he's he's starting to do endoscopic surgery now, and he goes, "What do you think? Is this a good case for a beginner?" And I said, "Absolutely, it's a great case. It's right dead center.
Yep.
It's right there winking at you. For me to do that case, maybe 25 minutes, and it's simple. It's simple. There's not much anatomy that you have to worry about it. It's not that deep." So it's a perfect endoscopic. It's actually goes from the center of the disc out far lateral, so it goes right across. Those are home runs, right? And I don't. Did he probably talked to you about that patient?
Yeah, he did.
Yeah. Well, I think we're going to do that endoscopically,
Oh,
and
cool.
I'd like you to be there.
Oh, I'd love that.
Because we'll do it on the day that you're doing your cases,
that.
and we'll do it together.
I would love that,
Because it's going to be a training day.
Yeah.
For Dr. Scoblar. And of course, he's going to be getting his certification in the procedure itself. But that's that. In fact, maybe it's a good idea after this case when you see how great it is. And I think you might have seen a couple of them. Right?
I've seen a couple, and I've done the. I'm certified on a.
All right, you did it with who? Joymax?
Eloquence.
Yeah, that's right. That's right. You did say that.
And then I've been to a couple courses.
And when you reach my age, I can remember everything.
No. But I'll make a comment though, which is an interesting thing that I've noticed with Dr. Jasper's practice and in general. I mean, it's hard as a doc to learn new stuff, and it's hard to kind of just sort of say, look, I what do you think here, and have that humility to ask another colleague for an opinion. And Dr. Jasper creates this great environment where there's plenty of docs, like, to Dr. Scoblar's credit, there's plenty of docs who would just go out and do a weekend course and then try it. Scary as it is, right. I'm sure for the people out there, the better way to do it is to have the humility to ask someone who's more experienced and then say, hey, can we do this together? Can you be around? Can you give me some feedback? And I think that's really, a remarkable feature. And that's how we've evolved, is by just talking, humility, cards on the table. What do you think? What do I think? What can we do to help this person?
I mean, that's a great topic right there.
Yeah.
To have not only continuity of care, but we share a lot of patients.
Yep.
And it's not only, Dr. Radcliffe calls me in, check this out. I call him, check this out. Dr. Scobler, check this out. And all of a sudden, we're all talking about the same thing. How can you get better than that?
Right.
You got different walks of life. You have different specialties talking about the same problem.
Yeah.
With different, we talked about this last time I think we were here.
Yeah.
And we got to keep repeating this.
Yeah.
To have the ability to have smart people that have an idea of what's really going on together with different techniques and different training is amazing.
Right.
It's amazing, and you can't get better than that.
Yeah.
And what Dr. Jasper alluded to, this is the perfect disc. Like, you get a sense in medicine and I guess in life about what you're good at.
Yeah.
Maybe, maybe somebody's not good at painting around their house, but they're good at, tile work or something. And certainly in medicine, it's not the dissimilar. I mean, you get a sense of what you're good at. So when we have these conversations, it's not chest thumping like, well, I can do this, that, do that. It's yeah, you know what? I know in my hands I can treat this,
Yeah.
but this other thing, I don't know if I can treat it or not. What do you think? Is there something you can do for this specific problem?
Right.
That's really, I think, what distinguishes, a center of excellence.
Yeah.
And you know what? And sometimes it's the ability to all of us work together and do
Yep.
what you more than just what I do. We do it together.
Right.
And they might need something that I can do well, then Dr. Scobler can do well.
Yeah.
and
Two,
Dr. Radcliffe.
all these
Yeah.
doctors
They
coming
might need
together.
the combination.
Yep.
Yeah.
It's really nice.
For like, the different experiences you guys have had, the different tool sets you've got now, coming together and getting advice from all these different circles, of influence. That sounds amazing.
And as we talked about in the beginning of the show about the new techniques and the new instrumentation that's coming out to make everything easier, safer, and better. I got a call the other day, text message from a rep from a specific company that we use, and left the company. And he said that now I'm going to become a distributor, which means that, and he told me, he said that means I don't have to have one device. So I can go out there and in his opinion, get the best devices out there and present them to us.
Oh, wow.
Now, what do I tell him? I said, listen, if you get anything new out there and good, you bring it right down to our center and
Right.
we'll look at it.
Right.
And if we like it, we'll use it.
Yeah.
If it's better, and we're loyal to everybody, but the people that we're loyal to need to realize that if somebody comes up with something better than you have, we're going to use it.
Yeah.
And don't be offended by it. So you better come out with it first.
Yeah.
Right.
Some people get offended, but
I
stick.
will say that's another thing. At some hospitals, I mean, it can be 3, 6, 12 months to get something new in. And it's kind of slow and laborious. Certainly the center is very nimble and can bring in, new technology as needed when it's appropriate, assuming it's safe and FDA approved and all that stuff. But once, I mean, we kick the tires on it pretty sort of in detail and make sure that it works well. And if it does, I mean, we can use it and employ it without, much delay. It's really good.
You talk about hospitals, not to bash hospitals, but we're here to bash some people. We got to make it interesting.
Yeah. Controversial.
But the fact that sometimes politically certain things can't get in to the hospital because maybe like the old days when the cardiologists all of a sudden started to do catheterizations,
right?
It would piss off the thoracic open heart surgeons. So they had a tremendous hard time trying to get them to actually get approved to do it. But guess what? Time tells.
Yeah.
They figure it out. The insurance companies figure out what's better for the patient. And now there's not as many open heart surgeries being done with coronary bypass today because you have the interventional. I mean, the big surgeons lost out.
Yeah.
Now you got the cardiologists going there with stents. They could remember the surgery I just talked about, the AAA abdominal aortic aneurysm.
Yeah.
That's obsolete now.
That's all done with stents.
They do it all with stents. They put in through the groin for the groin. They put in a graft that once they get into the aorta, they expand it and it's done.
Yeah. There's so when I do some surgeries, if I go through the belly, I have there's another doctor who's there to kind of move all the belly parts aside, and it's a little bit sort of scary to think like, oh man, they're gonna pull all my stuff aside, but the reality is that it is actually a great procedure because you don't damage the muscles around the spine. So there's a vascular surgeon who I work with, who's at Capitol Health, Dr. Eisenberg, and he is simply phenomenal. And like he and I talk about this, that the point Dr. Jasper made that like, I mean, vascular surgery has become so specialized now that the surgeons themselves are doing a lot of stents, and the skill set to be able to do that open, incision if you need it to repair a blood vessel is kind of, maybe not as prevalent in the younger generations. So that's why I choose to go to that hospital to be able to work with Dr. Eisenberg in particular, for my what we call anterior lumbar approaches. But it's totally true that you got to evolve in medicine. You got to be safe and make smart choices, but you got to evolve. And if you don't, you'll get left behind, and you'll do a disservice to your patients.
There's so many. I hate to say, there's so many doctors out there like that, but a lot of them are up there in age, and they're planning on retiring, and they don't want to learn new things.
Yeah.
Most doctors my age today want to retire, and I think it's mainly because of the politics and the insurance companies and the state board of medicals. There was looking at you with a fine tooth comb. It gets people suing you left and right without merit. They just sue because based on the economy, everybody gets sued when the economy's bad. Guess what? The economy's not that good right now, so everybody's getting sued.
Yeah.
But then there's during, and I hate to say it, but well, actually I like to say it, during the Trump era, very few people were sued because people were making money and they didn't need to sue anybody to make money. There was always somebody out there that's the way they live. There's certain people out there, but
yeah, a friend of mine says, I mean, it as a doc getting sued is it's tough, and it's tough for a patient to have a bad outcome, of course. But I mean, to some extent, the way I look at it, I got this from one of my friends, is I'd rather that like people can resolve their disputes in court where everybody gets a chance to say what they want to say, because the alternative is you hear about this where people are sort of doing violence on healthcare providers, on spine providers. And but yeah, Dr. Jasper's right. Certainly the economy is a challenge now. It's a challenge for a lot of patients.
Yeah.
Yeah, I got a question for you, Dr. J. What do you say to patients who say, my insurance company told me that an endoscopic surgery is experimental and unproven? Because that happens a lot. There's a lot of denials for that endo code. And well, I mean, I think that to some extent that may put people off on some endos, is that they get that letter that says experimental, unproven. What do you say to that?
Well, I tell them it's absolutely untrue.
Yeah.
Because endoscopic surgery has been around for 30 years or more.
Yeah.
And it's very easy. I give them studies.
Yeah.
Actually, I can give them 12 of my studies that I did a few years back that people use today as footnotes in their studies. You see my studies all the time. Not to mention the studies that were done way before I did endoscopic surgery. Endoscopic surgery is not experimental, right? And it has proven beyond a shadow of a doubt it is a very good procedure. And basically, what I tell a patient, it's simple. Why do they say that? Because they can.
Yeah.
And they don't want to pay for something. So if they could say that, then they might be able to get away with it. But what happens ultimately? What happens ultimately is you have to file an appeal.
Yeah.
And ultimately we get it approved.
Yeah.
Because we prove to the insurance companies based on these studies, and there are tons of studies, but believe it or not, most of the studies are done abroad because America is just not in, it's a little backwards when it comes to this kind of stuff as far as this endoscopic surgery in this country. But there are plenty of studies today that show, and I send it to them, and then I demand a peer review.
Yeah.
Which they have either an orthopedic spine surgeon, neurospine surgeon, or an interventional physician, pain physician that will call you and rationalize with you.
Yeah.
Of course, some of them, you got to get a good one, because some of them they read the rules. Well, this, it doesn't have that. By being and I'm sorry, doc, I agree with you 100%, and you are right. However, it doesn't follow this criteria. I'm not talking just endoscopic. I'm talking about stupid stuff. Like an epidural. If you don't follow certain criteria, or like an interspinous spacer.
Yeah.
If you didn't do physical therapy, took NSAIDs, had epidurals, you're not a candidate as far as the insurance company, and they'll deny it.
Yeah.
And I learned that the hard way when patients need the procedure, and then I get to a peer review, and the guy says, "Listen, do yourself a favor. Take a piece of paper out, make sure all the patients have this done before you submit it."
Yeah.
And that they don't usually tell you that because they want you to appeal it and never give the right stuff and never get it done and then give up.
Yeah.
So I wrote it down. Ever since we don't have a problem.
Yeah. I'll tell, I'll say one challenge is the physical therapy requirement. I feel like physical therapy has almost been weaponized by the insurance companies. And so it creates such a bad taste. You tell people, well, you got to do 6 weeks of physical therapy to get whatever, an MRI or to get this and that. And I would say for those people, if your insurance company insists you do it, go in there with an open mind, be honest with the therapist and just say, look, I don't think I can do this, and there is a loophole for most of the insurance companies that if the physical therapist says, this isn't a good idea for you, I'm going to discharge you. You don't have to do 6 weeks. You can do, 1 visit. So, just if you have to do it for your insurance company, give it a try. And realize it's not us forcing the physical therapy on you necessarily. It's nor is it the physical therapist forcing it. It's the insurance company.
So it fills the criteria because you've done physical therapy, whether it be 1 day or 6 weeks, and have failed.
Yep.
So it goes under the criteria. All right, we're having a great time here.
Yeah,
and,
we are.
And we're actually going into Dr.
Schneider's time now.
Well, who's after Dr. Schneider?
Nobody.
Well, I hope she doesn't have to anything to do because we went into her time a little bit. She's a very reasonable person. But we probably go another 2 hours to her. We got to do this again. Doc.
Yeah, we got to do this again.
Yeah, we do. We really do.
Yeah.
And I'm sure there are people on the other side of the pond listening to us. What time is it there? Yeah, it's like it's
my dad's listening to us. Yeah,
late afternoon, and we got a lot of buddies that with eloquence, and I still have a few buddies that are Joy Max that are listening.
I wanted to tell you that. Look at this. Well, we had Chappie saying highly recommended, very skilled doctors. We got Diane, step therapy. Pitching out ideas to talk about here. X-ray prior to an MRI, delayed. I need treatment. Oh, well. And of course we got Felix.
Hey. All right. Thank you, everybody. Give us a call, and we'll take care of you. Thank you for listening.
Thank you.
For more information about Dr. Gabriele Jasper and all the wonderful things he does, please go to jaspermd.com. You can make an appointment with Dr. Jasper by dialing 732-262-0700.
And how do they contact Dr. Radcliffe?
Yeah, and Dr. Radcliffe?
Yeah, so my website, spinaldisccenter.com, and my number is 609-800-DISC, 609-800-3472.
Fantastic. Thank you. Let's see him again. There he is. And Doc and